Spinal Truth Show Weekly Edition. I am your host, Dr. Caleb Slater, here with Chris, our videographer, and our local pelvic floor women's health expert, my wife, Danielle Slater. We are a show that gives you just a little bit different of a perspective on your health condition, your symptoms, something that the current medical system does a pretty poor job of, in my opinion. We will give you a different way of looking at your symptoms and hopefully a better way that doesn't just manage your symptoms, but actually looks for and addresses the underlying cause. Last week, we talked about men's health. This week, we're talking about women's health. And let's start off with, what are some symptoms and conditions that you commonly get from women coming in seeking treatment?
Yeah, and I think we're kind of targeting women's pelvic health to be specific, but we'll see things such as vaginismus, which is pain with any kind of penetration or sex, vulvodynia, which is the vulva is kind of that tissue right on the inside the labia, and that tissue becomes hypersensitive to the point where people will describe any kind of touch, even like wiping, to feel like glass tearing through or sandpaper. Things like just pain with sex without a known cause, which we would be considered dyspareunia. We also see things like nerve-related injuries where pain with orgasm, pain, Pudendal neuralgia, which we talked about on the last episode, but has a lot of similarities in the female population. So I'd say those are...
And I think those are a lot of words that I don't think a lot of people out there know. So if they're coming to you, I think one of the symptoms that you said was painful intercourse. So they're coming to you...
Yeah, or maybe a tampon use.
Painful insertion of anything, right?
Yes.
What happened to cause that, and what do you do for it?
Yeah, that's the million-dollar question. Sometimes there might be a known mechanism of injury or like a trauma to the area, maybe birth precipitated. But oftentimes it's, I don't know. That's the most causes. It just came on.
And we talk about this a lot, the idiopathic, right? Meaning it's the medical term for I don't know why. And if you look up almost anything that isn't specifically understood, which is so many more conditions than you would want in a healthcare profession, you're going to get either a litany of symptoms or causes such as genetic, stress, environmental, other conditions, trauma, but then you're also going to get unknown, idiopathic, and that's probably the most prevalent in a lot of these symptoms, a lot of these conditions. And if for my money, it's because we're not looking at the problems correctly. We're looking at them with the wrong lens. And because of that, they're getting improper treatment and poor results.
Yeah, I mean, it depends what doctor or professional you go to, what diagnosis you'll get from their lens. But if I hear, I don't know, it's my first suspicion of it's nerve-related.
Sure, and if it's nerve-related, where do you look? Is it local entrapment, or are you looking somewhere else?
Well, from a PT perspective, school, courses, drill, oftentimes local, chase the symptoms. But what we've learned after almost 16 years now of practice and endless courses you and I have taken is that wasn't effective, and it logically didn't make a lot of sense, and we weren't having great success. So now I'm looking central, I'm looking nerve, spinal cord, what's happening from that.
So somebody comes to you and they're saying they're having painful intercourse, difficulty with insertion, they're having pain with light touch. It used to be that you would look at that area, you'd evaluate that area, and now you're doing that, but you're doing that and then you're going to the spine to see if the spine is actually causing that problem.
Yeah, you could still obtain a baseline, because just like we do with, if you're having back pain, we want to obtain a baseline of how your symptoms are so we can test and retest and see how things are changing and improving. So you're right, you could still proceed, and sometimes I will and I won't depending on the scenario of a person. because it's invasive. It's invasive to have an internal exam. So I shouldn't just go on and subject every person I meet to one, and nor does every person I meet feel comfortable having one.
Well, sure, and they're coming to you because that area is painful.
It's painful, right.
It's painful to light touch or painful to insertion, and most pelvic floor clinicians, correct me if I'm wrong, they would then touch and insert into that area to assess.
Yeah, trying to be cautious and careful and mindful, where I'll hear a lot of times they're like, oh my gosh, at the gynecologist, that was so painful, they were so rough. But our approach, I would say, is a little different, and we're also not trying to go as far as the uterus and the bladder. We're looking at muscle pathology.
And this used to be your main approach, because again, like what you
Yes.
said, everything that's taught is taught to look at that area, assess that area, how well does it function, what the muscle contraction is, downtrain that area, contract that area, stretch that area, right? But you saw just
Mixed results.
Some people would help. And some people wouldn't help at all, and others it would help a little bit, and
They'd
it was
be back
just
a year later with
they'd be back
the
a year
same
later,
symptoms.
or it would help for a week, and you'd have to do some other stuff, right?
Or they weren't comfortable proceeding with that, and then you have to think.
And now, because we have a little bit different of a lens, now you're looking at the spine, the area of the spine that innervates this. So, and for the people out there, a lot of the pelvic floor is innervated by the L1, L2 area, the genital femoral and the ilioinguinal, right, nerve.
Yeah.
So coming from the L1, L2 area, so a little bit up higher in your lumbar spine, so kind of maybe a little bit higher than your belly button area of your spine, that actually innervates your pelvic floor, that innervates your genitals, that could cause painful intercourse, painful insertion, pain to touch, that nerve is irritated, and that's actually causing these symptoms. So now you're treating this area, and how has your treatment and your success been since you changed your approach?
Yeah, I think it's better. It's definitely better. And it's agreeable to everybody, because at worst case scenario, their back's going to feel better, they're moving better, and they understand more about their body. But the best case scenario that often happens is those symptoms are improved and resolved without ever having to be exposed to an internal examination.
And you still have that treatment option in your back pocket, so to speak, right?
Yeah.
Like, so, and this is the point that I try to get to a lot of my patients that I'm treating for some of the other conditions, like, Crohn's and ulcerative colitis, and even knee pain, plantar fasciitis, right? Like, we know the typical approach for plantar fasciitis. You stretch it, you rest it, an injection, orthotics, right? Like, tape it. That's the typical approach that you can look up and find anywhere. But we also know that it has mixed results. But my look is to go to the spine, and if the spine hasn't created significant improvement within 1, 2, maybe 3 visits, we still have the typical approach, right? We still have the typical approach that if it works, great, but if it works, it might not have explained the why. And that's really what we started looking for. We stopped accepting I don't know why as an answer. We stopped accepting I can't explain the cause as an answer, and we kept looking for, well, what could actually cause this? And for me, an irritation of the nerve at the spine that has now led to muscle wasting, weakness, muscle hyperactivity, decreased sensation, increased sensitivity, right? All of those can be caused by a nerve issue at the spine, and now that makes sense to me logically what caused it. It makes sense to me logically how to treat it, and the best of all is that I've seen results so much better, quicker, and longer lasting than anything that I've done before. If you'd like an appointment, go to thespinaltruth.com and schedule today. We offer both in-person and telehealth appointments, and unlike the medical system, we look to the root of your problem. We look to find the cause, the why your problem, your symptoms are there in the first place, and we expect quick improvement. We expect improvement in pain, range of motion, or strength in the first visit, and 50% or more improvement in most conditions within 4 to 5 sessions. So if you're tired of being in pain, if you're tired of the medical system and its approach failing you, and you want something different, go to thespinaltruth.com and schedule today. Now let's get back to the show.
Yeah, and the same goes with pelvic health. And
I think this is the information that we want to get out with this 3-part series that we've done over the last few weeks, is that it's known, and it's even poorly known within our own profession, that knee pain is often coming from the back. that elbow pain is often coming from your neck, right? There's a subgroup of physical therapists that treat like this, McKenzie physical therapists, but they're kind of few and far between, and a lot of people in our profession don't even treat like this. Most people don't, but we know it, we've seen it, right?
I think that's been like a jumping off point for you, and you've discovered that, yeah, some of that stuff was really helpful, but wow, it opened up a whole new world of things that you discovered movement-wise and treatment-wise to be
well, and so we said,
different.
so
And
if it can be your knee pain coming from your back, why can't it be your pelvic floor pain coming from your back? And as soon as we started doing that, everything changed. And this is the change that I want to see in the pelvic floor profession as well, because it makes sense. It makes sense to me logically. I've seen it work well clinically, and there are starting to be studies out there. You were involved a little bit in a McKenzie study that just didn't end up coming to fruition, but some guy in Canada was actually treating this, right?
yeah, there's been a lot of interest from small groups of we're not the only ones seeing this. There's a connection outside of the tunnel vision of just treating a bladder, just treating your pelvic floor, that things are connected, and the nerves that are coming from the back and the spine are involved and play a part.
Yeah, and worst case scenario, you look to the spine, you attempted treatment, it didn't work. Now you can move on knowing that you kind of checked your boxes, and now you're moving on to something that might be a little bit more invasive and something that we've tested a little bit. We've given it its try, we've given it its due diligence, we've given it its day in the sun, and it helps. It helps some people, but it doesn't help enough for us to stop looking for something else.
No, and people want to be able to find a solution, and even if we look at one of those syndromes like vulvodynia, the extent to solving that problem can lead to surgery of removal of the vulva, or a part of the vulva that is highly sensitive. So having surgery to remove part of your vaginal tissue is the extent of it.
Which doesn't sound great, right?
No,
and
not pleasant.
I can't speak to that, but if you wanted to take a part of what I have going on, I would not be thrilled.
I'm sure you would not.
Right? And before that surgical resection, removal, some of the treatment, correct me if I'm wrong, is Botox.
Could be. It could be in just even like steroid injections. But yeah, injections, needles into your vaginal muscles, tissue area. It could. So you're right. And it's medications too, which have their own side effects. And that is definitely last of the line, and it's not overly common, but that's what it can result to. And if you're on a quest to heal your pain and that's what you're offered as the last available treatment, you're probably going to be willing to try it to get out of pain.
How many patients have you seen that have had injections, Botox, cortisone, pain injections?
100 plus.
Well, but you're saying this is a last resort. But
no, I'm surgery.
Oh, okay.
So
the resection.
A vulvectomy.
Okay, so the
That's a handful.
The injections are sooner, right? Which makes sense,
Sure.
right? But you said you've seen hundreds of these patients that have had these injections. How well does it go?
It's a mixed bag, but overall, I feel like it's not their lasting cure.
Right. If they had the injection and they're seeing you,
and they're usually expressing it was painful. It's painful to be poked.
Sure.
With needles and
I don't like getting a flu shot.
My private area. Yeah. So this is usually multiple injections. It's not usually one. It's usually being poked several times. And if it's Botox, it's expensive. It's usually not covered, and they're shelling out $500+ to be able to have.
And Botox, the point of Botox is to paralyze the local tissue.
Yeah, thinking that it's like always turned on and contributing to the problem. So we turn it off and we get it to turn off for a few months, maybe the problem goes away. But it doesn't always work that way. And if some of that tone is necessary because it's helping maintain.
Sure, I've heard muscles have function.
Yeah, pressure on your urethra so that you don't pee your pants, or pressure on your rectum so you don't poop your pants. So those are all side effects that can happen, and hopefully temporarily, because Botox does wear off.
Yeah, about 3 months, somewhere around there.
I'd say up to 6, but yeah, everyone's a little different. But yeah, so if there's an approach, and this approach hasn't really been offered to anyone to be able to try that first.
How many patients that come to you with the diagnosis of vulvodynia, vaginismus, dyspareunia, Pudendal neuralgia, interstitial cystitis, overactive bladder, all of these conditions, how many of those patients have been offered a spinal approach before they get to you?
Say nobody yet. It's not a commonly utilized approach, but I think your mission and our hope is that someday everyone's been offered that as a screen before they're taking next steps and more invasive, more expensive, more painful steps.
Yeah.
That are just kind of, a lot of times in our opinion, just be a Band-Aid to the symptom rather than really figuring out
and like what
the
we're talking
mechanism.
about, steroid injections that often have pain medication in them, they are a Band-Aid. They are just numbing you to your symptoms. And don't get me wrong, if I'm in that much pain, hey, I'll take numbing all day long, right? But I also want to find the underlying cause. I want to fix the underlying problem. I don't mind being numb temporarily. That sounds good compared to being in pain and having that much pain, especially in that area, right? Like you might need relief in order to be able to get treatment. I get that. But what happens so often is that patients are sold these procedures, the Botox, the cortisone, the pain medications, the pain injections. They're sold these as a cure. They're sold epidurals as a cure. They're sold nerve ablations as a cure. And none of these are a cure. All of them are just numbing you to your symptoms and hoping your body gets used to it. And then by the time they wear off, the effects wear off, you tolerate it better, or you don't notice it anymore. But what happens is that this problem evolves, it worsens over time, and as it worsens, your symptoms change. And as your symptoms change, now you start chasing symptoms.
And I agree, all those are offered, and I think they're offered with good intentions and hope that a lot of people get into healthcare because they want to help people. They want people to feel better. It's just the only thing they have in their playbook is to offer medicine, injection. But if you can now have something even a little simpler, such as a spinal exam and treatment, I think you have a way to really reform and help healthcare.
Yeah, I obviously I agree, and that's our point here, is to get this information out to people and make meaningful change in the medical profession that I think is needed. We went, since the 70s, 80s, we took a pretty hard line towards the pharmacological approach. And again, I get it. If I could take a pill that takes away my pain, that makes me smarter, stronger, better looking, sign me up. But what we found is that it's either temporary or it's ineffective ultimately. It's just numbing you to your symptoms. It's just managing your symptoms, just a Band-Aid, or it's causing so many other problems, so many other complications that it's not worth it in the first place. And so we haven't found that magic pill, that treatment, and we've seen the limitations of this approach. And your body's pretty cool. Your body, it can tell you what's wrong if you're willing, if you know how to look for it, if you're willing to listen, and you can also figure out how it can heal itself, right? You can figure out how to take pressure off of a nerve. You can figure out what muscle isn't contracting or what muscle's contracting too much, and you can fix that. And in doing so, take pressure off of a nerve, that muscle putting pressure on a nerve, or compressing a joint, which is putting pressure on a nerve, right? You can fix it if you're willing to look for it, but it does take some time and it does take some effort. And most of the time in our current medical system, the physicians don't have the time and the patients want a quick fix.
Yeah, I was going to say, I think it's important to note too, I just found a study from 2016 that shows that 16% of women in the U.S. suffer from vulvodynia.
Okay.
It's a really high.
Well, and so, Chris, at the beginning of this, you're saying, well, this is kind of an uncommon diagnosis, but 16% of, I'm assuming it's about 150 million people. Probably, yeah. So we're talking large numbers. We're talking 22.5 million, I think, if my math is right.
And I mean, it extends to, it might not just be vulvodynia, it might not just be it hurts when I use a tampon or I have sex. It might be it hurts just when I'm sitting. I'm uncomfortable. Like, you know how nerve pain would feel? Many people have had an experience where they've had nerve pain maybe in their leg.
Yeah, so sciatica, right?
That pain in your private area, like can drive you mad.
Sure.
And it can mess up your relationship. Like, it has a lot of even day-to-day effects, let alone relationship effects.
Well, the same study cites that vulvodynia is the most common cause of painful intercourse for women in their reproductive years. So yeah, then not only at that point would it affect the woman, but the relationship potentially if, sexual intercourse is uncomfortable for them.
You've had a lot of patients that you said that they haven't been sexually active with their partner for months to even a year because of this, right?
Yeah, I mean, I've even met someone who sex was so painful, they wanted to have children, so she had to do IVF to get pregnant. Like, it goes to a lot of expense and really changes the dynamics of relationship.
If you're out there and you're in pain, if you're tired of the current medical system failing you over and over and over again, just giving you answers that numb you, pacify you to your symptoms, and are largely based on medication, injections, and surgery, and you want a different way, maybe even a better way, look for my book, The Spinal Truth, A New World of Medicine. In it, each chapter I talk about a different symptom, different condition, different body part, and how I view it a little bit differently than the current medical system, and how my treatment has helped so many people out there when they've been let down with the typical approach. This is the way I think medicine should be. This is the change in healthcare I think we deserve. So thespinaltruth.com, you can look for my book on Amazon, Kindle, Apple, and on audio.
It is a very difficult diagnosis to treat and help just via the pelvic floor. I feel like if you can calm the source down, then you can have greater success.
Well,
so if there's an underlying nerve irritation, then although there may be subsequent, you've talked about this, so you first fix the cause via some spinal approach, you're addressing that nerve. But then if there is some development of abnormal tissue tone, that's quick to fix then. That should just take a couple visits. But when I would just go in for pelvic floor treatment and have that vision and only treat that way, I'd be treating patients for months, and I feel like it was just up and down, and we're not getting a few sessions of treating that symptom.
So to put that more into maybe layperson terms, right? Like, if I wanted to strengthen my quad, but that nerve wasn't getting to my quad, I could still strengthen it. Like, if the nerve is partly getting there, I could still strengthen it. I could still go to the gym 5 times a week. I could still do squats and lunges and leg press and all these other activities, and I could still see some improvement. But I'd be so much better served to fix the problem with the nerve, turn the nerve signal on, and now anything that I do, I'm going to be not only stronger, I'm going to recover better, I'm going to see more gains, and I'm going to have less symptoms during that time. So I'm going to be successful now. So I set myself up for success because the weakness in my leg was just a symptom, and the underlying cause was a nerve issue. So yeah, I can make my leg weakness a little bit better with exercises, but I can spend my time better if I fix the underlying cause. And now, if needed, now I can strengthen my leg with more success, with quicker gains.
It's the famous saying about like a little bit of preparation.
An ounce of preparation is worth a pound of cure, right?
There you go, right?
Right.
That's kind of
So,
what
and
this
well,
is.
and so this is kind of the, if you want to go with sayings, right? It's like, if you give me 4 hours to chop down a tree, I'm going to spend the first 3 hours sharpening the axe. Sharpening the axe, like that's your, let's address the cause, and now anything that we need to do, we're more successful.
Is this one of those conditions where it has a whole host of symptoms that could apply to many things?
Likely, I feel like it sometimes is hard for women to get their diagnosis correct, and it takes a long time and many practitioners, so I would say yes, that it can be.
What diagnoses could fall under sensitive tissue, right? So I mean, that's kind of the underlying issue, right, is sensitive tissue. What other diagnoses other than vulvodynia could be applied to that?
Sure, Pudendal neuralgia, like dermatological things like lichen sclerosis, which is change in tissue composition and leads to like increased like a thinness of the tissue where it frays easily, bleeds easily, hypersensitivity just in general from pain-related experiences.
Isn't there chronic pelvic pain?
Sure, yeah, diagnosis of, and that's kind of like a catch-all term. And
So one symptom can lead to 4 or 5 different diagnoses, right?
most patients almost have a cluster of
Yeah. And
diagnoses
I
that
write this in the book, I think specifically in the knee chapter. I said you could take your knee pain and go to 5 different doctors and get 7 different diagnoses. You know, your knee can be meniscus and patellofemoral syndrome, and it can be
I agree. Yes, you're going to hear different. If you haven't told them what the last person diagnosed you with, you get a totally different outcome. You'll hear patients say, this doctor said I need surgery. This one said I don't need surgery. This one said it's this. This one doesn't agree.
Yeah, and again, why do we have so much disagreement in the medical community? Why do we have so many diagnoses that have multiple causes or no known cause, right? And it stands to reason that we're not looking at it right. We're looking at the symptoms, we're not looking at the cause, and since we started looking this for the cause, and the cause took us to the spine more often than not, we've been so successful in not only treating the patient, but actually explaining it in a better way than is currently offered. And this is the information we want to get out there because of the success that we've seen, and because we think that if this gets adopted by more medical professionals, we can see some meaningful change in the medical profession, not just our profession, physical therapy, but others like chiropractic and physicians and DOs, that we can see better healthcare that's actually addressing the root of the cause.
So we do have time for one question here, and this is related to birth. Christy says, okay, so I have a bizarre one. I never ever in my life had foot pain until after the traumatic birth of my baby in December 2022. It was immediately noticeable, but it's like the side of my foot, ?
I think actually this would be fielded a little better from you.
Yeah,
because
we talked about this in
inevitably
the pregnancy talk, where a lot of women get sciatica, and the outside of your foot is innervated by a branch of the sciatic nerve, and the baby causes your spine as it grows to get a lot of pressure on the front, which distends the spine to move in that direction, but it also makes the other side of your spine shorten and put pressure on the nerves. And birth is trauma in and of itself, but it's also gradual trauma to your ligaments, to your muscles, to your tendons as that baby is growing and putting pressure and distending your abdomen and shortening the back of your spine, right? So that's trauma in and of itself over a longer period of time. It's basically the definition of creep, a low load over a long period of time that deforms the tissue. And then you have the trauma of birth, and then after this has all happened, you don't get out of that position. Nobody tells you to stretch your spine in the opposite direction. Nobody tells you to contract your muscles to move your spine all the way through in the opposite direction. So you just stay stuck like that. And that's why a lot of these patients get hip pain, knee pain, thigh pain, leg pain, sciatica issues, lower back pain, lower back weakness feeling, catching in their hips, popping in their low back, catching in their low back. All of these symptoms basically come from instability because you're weak and your spine is stuck in one position. So if you want to know a little bit more about that, if you want to go to our pregnancy podcast episode that we did about 2 weeks ago, we talk a pretty good amount on that, and I give you some things to do. So thank you for being here for our show, the Spinal Truth Weekly Edition. Today we talked about women's health. We have just wrapped up our 3 weeks of pelvic floor talking about pregnancy, men's health, and women's health. Next week we're going to go on to a new subject talking about sleeping positions and how to better sleep, how to get better sleep for you. If you were listening today and you want to know more about a specific diagnosis or symptom, leave us a comment below. If you have questions about something else or a topic for the show, you can leave a comment as well. If you'd like an appointment, you can go to thespinaltruth.com. We treat both in person and via telehealth. If you want to leave us a comment on social media, we have Instagram and TikTok as well as Facebook. Thank you for watching. We'll see you next week.